much. My name is Serrao. I'm very excited today to present our work in implementing a sickle cell disease screening initiative in Uganda with HemoTypeSC. Disclosures: I'm an employee of Silver Lake Research. The role of our company in the project was to fund the study, approve the study design, and donate the HemoTypeSC tests. So some facts about sickle cell disease, which many of you may know: up to 3% of births in Africa, parts of Africa, are affected by sickle cell disease. The unfortunate fact is that the vast majority of all of these children will die undiagnosed before the age of 5 years old. Sickle cell disease is thus a leading cause of childhood mortality in Africa. And although this disease is recognized as a public health problem by the UN and the WHO, African governments and ministries of health still largely neglect this disease. Diagnostic screening of newborns and young children, followed by treatment, prophylaxis, and counseling, has been shown repeatedly to dramatically reduce the mortality of this disease in more high-resourced regions. However, sickle cell disease screening has not been widely implemented in Africa, and so individuals with the disease are commonly identified only after they die or when they present at the hospital with life-threatening symptoms. So why is it not widely implemented? Well, gold standard methods used to diagnose the disease are not suitable for Africa, or for most parts of Africa. So these machines listed here are expensive as an upfront investment, or even if they're donated by an organization, they're usually just one machine within a wide diameter of geography. These machines are expensive to maintain. The reagents are not widely available in many cases. This leads to an unaffordable cost per test to the patient, and so it's not frequently diagnosed. Furthermore, these machines require a large volume of blood to be collected to run the tests, and so small infants and newborns sometimes are not even amenable to screening at all. Or if they are screened, it's very traumatic for the baby and for the mother. I can tell you from experience seeing this. Lastly, the blood specimen with these techniques has to be shipped away from the point of care, and the results must be shipped back to the point of care. So a lot of children are lost to follow-up. Even if they're diagnosed by these machines, they'll never get their result and will die anyway. So HemoTypeSC is a new test that Silver Lake Research has developed, which is a solution to all of these issues. It's a rapid test for sickle cell disease. It's a lateral flow assay dipstick test that relies on highly specific monoclonal antibodies for hemoglobins A, S, and C, which are involved in sickle cell disease. Each of these antibodies has less than a 2% limit of detection, so extremely sensitive and specific. It's an uncomplicated and rapid procedure. It takes 10 minutes and just one droplet of blood. The entire procedure is listed, as shown pictorially there. I can just go through it. You drop 6 drops of water into a test tube. Use our included blood collection device, which is just a paper strip, to collect a drop of blood from the newborn's heel or an individual's finger. You put this blood into the water and then insert the HemoTypeSC test strip and wait 10 minutes. So this test is ideal for Africa and rural regions of the world. It's inexpensive at less than $2 per test to the end user after it's already in Africa. The results are delivered at the point of care, and this test has been shown recently in American Journal of Hematology to be very accurate in newborns and children with high fetal hemoglobin. So in this initiative here, we aimed to implement a sustainable sickle cell disease screening program with HemoTypeSC at a major hospital in a high disease prevalence region. So we selected southeastern Uganda, which is a region where 1 in 5 childhood deaths are due to sickle cell disease. We established a collaboration with the Sickle Cell Association of Uganda, led by Ruth Nankanja, who did an amazing job here. And our study site was the Jinja Regional Referral Hospital, which is a typical resource-constrained medical center. This was a blinded prospective diagnostic accuracy study of 1,000 children aimed 1 month to 5 years of age. These were recruited from the hospital wards and outpatient clinics, and we compared HemoTypeSC as the investigational test to capillary zone electrophoresis, or CZE, as the reference test. And just as a point, this test cost $12 per test, even in our study. So the administrators of the HemoTypeSC test were self-trained via video procedure on the product website, hemotype.com, and also the kit instructions. These are the demographic attributes of the patients. Approximately equal male and female, and in terms of age, relatively even distribution across the first 5 years of age. Importantly, I've circled there that about 20% of individuals were between 1 month and 1 year of age, which is a time of life when fetal hemoglobin is at its highest and also a prototype age for immunization clinic screening programs, which is a time when children can be caught, if not caught, at birth. Here's the data comparing HemoTypeSC to CZE, the electrophoresis reference method. Long story short, HemoTypeSC results match the reference test for 998 out of 1,000 specimens screened. 720 normal individuals were also classified as normal by HemoTypeSC, and there were 2 discordant specimens, 2 specimens not matching between the 2 methods. The capillary zone electrophoresis identified these as homozygous S, or only containing S, hemoglobin S in the blood, whereas HemoTypeSC identified these as hemoglobin S trait, so having hemoglobin A and S in the blood. So the initial analysis showed that HemoTypeSC demonstrated a 99.8% overall accuracy. An interesting fact was that the final step in our protocol was to retest any specimens that gave discordant results between HemoTypeSC and CZE by a secondary reference method in order to determine which of the 2 testing methods was actually correct. So we chose HPLC as the secondary method. The 2 participants were recalled for a secondary blood draw to enable this secondary testing. And as the test administrators contacted these patients to recall them, the patient's mothers in both cases revealed that the children were originally diagnosed previously with homozygous S sickle cell disease and had actually both been recently transfused with hemoglobin A blood. And so the study administrators requested and confirmed the diagnostic results as well as the transfusion reports. And so this confirmed that hemoglobin A actually was in the blood of both patients at the testing at a trace level, probably below the limit of detection for capillary electrophoresis. And so therefore the true phenotype at the time of testing was hemoglobin A and S in the blood. Therefore, our secondary data analysis demonstrated that HemoTypeSC reported 1,000 out of 1,000 specimens correctly in terms of the hemoglobin phenotype for a 100% overall accuracy. So the significance here is that HemoTypeSC is an accurate, inexpensive, rapid tool that can enable sickle cell disease screening programs across rural areas of Africa and India where it's not being screened for at all and children are currently dying. The test is less than $2 per test to the end user in these countries. We've reported multiple times greater than 99% accuracy, and the test is easy to use with no reported issues in this study of any difficulty with the protocol or reading the results. One limitation is that the youngest age screened was 1 month, and so we didn't include any newborns in this study, but I would point out that recently in the American Journal of Hematology, we screened 57 newborns and demonstrated, again, 100% accuracy across multiple phenotypes detected. Sickle cell disease screening programs have been projected to be cost-effective in Africa, could actually save significant amounts of money for governments as budget is allocated towards screening and less towards identifying the disease after patients present with life-threatening symptoms. Early screening plus treatment plus counseling can save millions of lives over the coming decades, and we're excited that HemoTypeSC could form an integral part of the beginning of this equation. So I would acknowledge the Uganda clinical team, which did an amazing job carrying out this large study. Also, the Silver Lake Research Development team spent 5 years developing this test with NIH funds, and we're very excited to present this data at ASH. And thank you for listening.